Thank you so much for having me, and it's been lovely to meet with many of you so far. So, as introduced, I'm Abigail Greenleaf. I work at Columbia University. My main appointment is at a Center for Global Health called ICAP, and I'm also affiliated with our Department of Population and Family Health. So, I'm excited today to talk to you about research I'm doing in Eswatini. And as mentioned in my introduction, I love mobile phone surveys. This is a mobile phone survey, so I'm looking forward to sharing our ongoing results with you. So a quick outline of our presentation. Of course, we'll have a background discussion of the study design itself. In the method section, I'm going to go into detail about sequence analysis. It's a newer method for me. I was trained at a school of public health. I hadn't actually heard of a sequence analysis until June, when one of my mentors, who's a sociologist, said, Abba, you're kind of just doing a brute force sequence analysis by color coding all these outcomes. Could you just do the real thing? So that's how I got to the sequence analysis I'm doing today. I'll present some descriptive results and then the sequence analysis results, and then look forward to your questions. So why not do the acknowledgements up front? I have a funder at NIH that is funding this grant for 5 years. As mentioned, I'm newer to sequence analysis and couldn't have done this analysis without this 2023 textbook, which is excellent, which one doesn't often say about textbooks, but it really is. They have companion R code that's available for each chapter. So even if you're not interested in sequence analysis, but you want to have some great data visualization code, this is a great place to start. And then I think it's important for me to acknowledge what I'm bringing to the research, who I am, because that, of course, impacts the questions we ask, the way we look at the data, and the way we report it. So the work I'm doing is in Eswatini in Southern Africa. I am American. I'm from Iowa. I've spent some time in Eswatini. I lived in sub-Saharan Africa half of my 20s, but I am an outsider to that context. I'm lucky that ICAP, the Global Health Center that I work for, has an office in Eswatini. They've had an office there for 21 years. So I'm able to work very much in tandem with my colleagues there and Ministry of Health colleagues, but I have a very different profile from the young women that I am studying. I'm older than them. I have a very high level of education. I'm looking at things through a demography and public health lens. So let's dive into the context. I'm starting very broad just to give the context of what HIV has looked like in sub-Saharan Africa. So you can see in 1990, Swaziland, now called Eswatini, had an average life expectancy of almost 60 years. Because of the HIV epidemic, by about 2005, it was down to 46, 47 years old. So the HIV epidemic has had a profound impact on life and well-being in sub-Saharan Africa. So where are we these days? As of 2023, the greatest burden of HIV continues to fall in Eastern and Southern Africa. You can see there's 20.8 million prevalent cases of HIV. That's the most in the world. And it's not all thanks to PEPFAR. PEPFAR is the President's Emergency Plan for AIDS Relief, but the US government under George Bush actually created an HIV program that has had a profound impact in sub-Saharan Africa. So it's something that from a global health standpoint, we're very proud of. We've worked with Ministry of Health colleagues, and it's been part of the reason there have been improvements. So you can see the number of newly infected persons living with HIV, still a pretty big impact in Eastern and Southern Africa, but we see now that Eastern Europe and Central Asia are growing. But I'm still going to be talking about Southern Africa today. Just one more context slide before I really home in on the group that we're looking at, adolescent girls and young women. We see that there actually has been great progress in sub-Saharan Africa. There's been an incredible group of people working in sub-Saharan Africa to reduce new HIV infections. We've got some new products I'm going to tell you about that are very exciting and we hope will impact population level HIV. But you can see that progress has been made. So let me talk a little bit about adolescent girls and young women, the topic of my study today. So young women in sub-Saharan Africa are generally disproportionately acquiring HIV and have shouldered a disproportionate part of the burden from HIV epidemic onset. 78% of new cases among adolescent girls and young women are in sub-Saharan Africa, although that is not where it's not 78% of the world's young women are in sub-Saharan Africa. So it's disproportionate. Southern Africa accounts for 1/3 of the global HIV burden. And you can see in this map the southern part of the African continent has the highest HIV incidence rate among adolescent girls and young women. So what are we doing about it? We have two main intervention strategies. We have PrEP and we have condoms. So PrEP is pre-exposure prophylaxis. This is preventative medication for people who do not have HIV but are at risk of acquiring it. So there's a couple of different ways to take PrEP. The most prominent way in sub-Saharan Africa currently is daily oral PrEP. So last fall with one of my mentors, I read the manuscripts that reported results from daily oral PrEP studies. The first one is from the US, and we found it was really effective. The next was from sub-Saharan Africa among women, and we found that people had a very hard time taking the daily pill. So it is not as effective in sub-Saharan Africa among this population. Because of that, people continue to look for other modes and methods of administering PrEP. So we have a vaginal ring as well as a 2-month injectable. It was actually a very exciting public health moment to be a part of this summer. I was in Munich at the International AIDS Conference when the results from the lenacapavir clinical trial were announced. In a hall of like 1,000 people, everyone stood up and clapped for a few minutes because it is a very exciting finding that it was 100% effective against HIV. So it's a 6-month injectable PrEP. What that means is people don't have to go to the health facility except every 6 months. That makes people's lives easier. That is one of the challenges with the current ways of administering PrEP. So there's very high hopes that lenacapavir will reduce HIV incidence in sub-Saharan Africa. Of course, we have condoms. Condoms, I looked up. They have the earliest known visual evidence of condoms is from cave paintings dating back to 200 CE. That was a fun fact I recently learned. But the thing about condoms, if you've had the human experience of using them, it is hard to use them consistently. And we know that as a relationship continues, condom use declines. So condoms are an important part of our HIV prevention package, but we know that it is really difficult and people, we want to empower people and we want to empathize with the lives that they're living, but it is hard to use condoms consistently. So where am I looking at HIV among young women? I'm looking in Eswatini, formerly known as Swaziland. It's this country on the map highlighted in red. It's very small. It's 1.2 million people. It is still predominantly rural. The total fertility rate is low. However, there's still very high unmet need for family planning. Most young women are relying, 70% are relying on condoms as their main form of contraception, which again, as I said, it's hard to use them consistently, so they're at high risk for undesired pregnancy. Eswatini has a lot of great strengths, and it's a wonderful country. I've got to spend some time. It does have the highest HIV prevalence globally. So 1 in 4 people in Eswatini are living with HIV. That means it is also the leading cause of death. We also see as young women age, the HIV prevalence increases. So among those 15 to 19-year-olds, 7% are living with HIV. And among those 20 to 24, 21% are living with HIV. The last bullet point on the slide has to do with mobile phone ownership. Why? Because I want to share the context of the study. I've done a lot of mobile phone surveys in sub-Saharan Africa, and I can get quite cranky about them because people like to do them without thinking about who are you actually reaching. I'm lucky that in Eswatini, and it's one of the reasons we're doing this study there, not only the public health context, but enough people own cell phones that we can get a hold of a representative sample. So I'm not trying to create representative estimates, but I do still want to have a general idea of trends in the population. So why am I conducting a study about HIV prevention practices, namely PrEP use and condom use among these young women in Eswatini? Well, very little is known about the dynamics of protection from HIV because face-to-face surveys are too expensive and time-consuming to collect repeated measures. I don't know anyone that really has the budget to go to someone's home every 2 weeks to collect data. So it has been a real challenge, and mobile phone surveys have only really become realistic in the past 10 to 15 years in sub-Saharan Africa. So we've been relying on important face-to-face surveys, but it is the time to start learning more details about how people are taking action against HIV so we can better address the epidemic. Because we haven't been able to collect data consistently, we often don't look at condom and PrEP use together. We usually just look at PrEP use. Condom use is often asked in the last 3 months, have you used a condom? We often ask at last sex, but that's not really giving us enough of a picture. Another reason I'm conducting my study is because Most of the studies about PrEP in Southern Africa come from clinical trials or health facilities. So this is not to say clinical trials aren't good. We need them. They serve a very specific purpose, but taking a look at people more in their day-to-day lives and how they're using PrEP gives you a very different view than someone involved in a clinical trial who knows, that this is the main interest people are looking at is PrEP. So it's nice that we're able to use a population-based sample that I'll explain shortly. Another reason that we wanted to ask our research questions, which I'll present shortly, are because prevention effective adherence is becoming a more popular concept in public health. So what is prevention effective adherence? It's the idea that you don't have to take PrEP every day for the rest of your life. You should take PrEP when you are at risk of HIV acquisition. So it's the idea that you should be timing when you take PrEP with when you're at risk of HIV. This is a shift from the previous thought that you should just take PrEP all the time. So we want to know, is this actually what people are doing? We also need to create better metrics for PrEP adherence, persistence, and continuation, because right now they're mostly cross-sectional measures. And as you'll see, most people do not persist on PrEP. They don't stay on PrEP. And so we're kind of overestimating PrEP use with our current metrics. So all these motivations, what am I actually doing? I am the principal investigator for a study called The Dynamics of Contraception in Eswatini. I have a great comms guy that came up with DICE as my acronym. So the DICE panel is women ages 18 to 24. I recruited them from a nationally representative household survey I'll tell you about later, and they consented to follow up. So we call them every 2 weeks to ask about pregnancy desires, contraceptive dynamics, sexual activity, HIV risk, PrEP use, and HIV testing. So this is innovative to collect data this frequently, even around the world. It's pretty rare to have this high intensity of data to call every 2 weeks for 2 years. So we're really hoping that we'll be able to better describe these young people's lives to support them as they're going through this aging process where so much happens in those key years. I'm very lucky to work with an excellent working group. I've got Ministry of Health colleagues that I meet with monthly, meeting with them tomorrow morning. I've got this ICAP staff who are in the office in Eswatini. And I'm also really lucky I get to talk to my interviewers every 2 weeks, and I'll tell you a little bit more about them as well. So this is my study, and here's what we're trying to achieve today with the talk. So first, I'm just going to describe PrEP and condom use patterns, because very few studies have been able to describe their use in detail over time. Next, I'm going to identify HIV prevention behavior groups based on sexual activity, condom, and PrEP use patterns. This is a little subtle foreshadowing, as they say on TikTok, so you can see the groups that I came up with, and you can imagine which color might be those who are not sexually active. You can think about which color might be those who are not using condoms. And then finally, I'm going to share the characteristics of the group members in each HIV prevention behavior group. So let's dive into some of the methods. As I mentioned, I recruited all the young women for this study from a nationally representative sample. So that is really the best way to do a phone survey in low and middle income countries. You can do a random digit dial, but it's very hard to get a hold of young people in particular. So I was lucky that we're able to follow up with these young people who participated in a 2021 survey. I have over 200 questions for them, as well as biomarkers. So again, anyone who was 18 to 24 years old this year, female, provided a valid phone number and consented to follow up, was called in March of this year. So we called and we asked kind of 4 subject areas, mainly taking questions from SHIMS 3, but adding a lot more questions about their sexual partners. And at the end of that study, we said, hey, would you mind consenting to another 2 years of data collection every 2 weeks? And I'll show you the response rate. People were willing. So we're going to be calling them up to 52 time points. And every couple of months, we add in another couple of questions. So we add in what we call bi-monthly modules. We ask people about their experiences using health facilities. We're going to ask them about reproductive coercion next. And we've asked them about their contraceptive knowledge, like how to use a condom, when is a woman most fertile. So let's talk about kind of our phone baseline or the enrollment. So our 2 interviewers collected data for 17 days. They placed up to 2,233 calls. So this was a big undertaking, which meant that they called the 794 people sampled up to 5 times. Of course, if someone enrolled the first time, we didn't have to call them back. And 326 women completed the baseline, of whom 97% consented to being called every 2 weeks. It's a very different culture around data collection in sub-Saharan Africa compared to the US. So we enrolled 40% of the sample. I was hoping for like 50%, but I don't think I was being honest with myself. Like, it is really hard to get a hold of women, and especially young women. So we are happy with our 321 that enrolled. So now that we have completed baseline data collection, we're calling these young women every 2 weeks. So our interviewers call from Thursday to Monday every other week. They call each about 160 women. They're calling the same women. So they have developed a relationship, which has some pros and cons I'll talk about later. We have a supervisor who monitors in real time. I'm also looking at the data along with a research assistant. We use Survey CTO. So I had originally used Survey CTO for some of my cross-sectional data collection, but if you're ever thinking about a phone survey, it's a great product because they have lists of people to call and it removes people once you get a hold of them. So it's a really nice interface for that. And finally, we do give participants a reimbursement up to $1 if they participate in 2 calls and 50 cents if they participate in 1 call. So let's listen to our 2 interviewers do like a day in the life of being a DICE interviewer.
Bright morning, and we are making our way to work, and upon arriving at work, we greet our colleagues that we find outside, and we have a chit chat while we make our way to the office. And upon opening, I remove our notebooks, our earpieces, and our tablets, which are our primary data collection. And then before data collection begins, my colleague excuses me because we value confidentiality when collecting data. I like to begin my day with a hot cup of coffee, which I get, and then I settle down and begin assembling home. On the other office, my colleague has already begun, and she's also numbering her work and organizing it according to the dates and the outcomes of the polls that she's about to make. And she has her standard operating procedures on job aids on a table just to make a quick reference on. And she has already begun collecting the data and entering it into the clients coming into the tablet. So as she does that, she documents the outcomes of each call with a red pen if the client was not available or in our communication for call. So I continue with my data collection. I also document my outcomes of the call, client that's to call the lunch, which now is about lunchtime. And my colleagues switch on the tablet so that we make our way to lunch. And we like to ensure that all our study material or documents are kept safely and are password protected, which is why we put away our notebooks and tablets. And it's lunchtime. We are having lunch, and she found me still working, so I had to wrap that up. And we have lunch, and we are done with lunch. It was a quick lunch. And then she excuses me again. It was almost the end of the day because this was my last participant for the day. And I had to wrap up everything and put it back into the cabinet where we got them. And my colleague also comes over to hand over her working material, and we lock the cabinet again. We lock it in the morning and lock it in the evening. Then we wrap it up. And we are done for the day, and we lock our office, and we return the key to the office we got it from. Again, we retained into a lockable drawer. This marks the end of the day, and we say our goodbyes to everybody in the office, and we had a productive day. We hope you enjoyed it. Bye.
So I hope that gives you an idea of kind of the day-to-day of collecting phone survey data. And one thing I've enjoyed about this project is developing a relationship with these 2 interviewers. They're very honest about what's going on. When I spoke with them on Thursday, they were saying, Abba, we really do think at this point there are some young women who are having sex but not reporting it. They're like, so they have a boyfriend. It doesn't make sense that at this point they haven't had sex. We've been interviewing them for eight months. And so we talked about how they could approach that, reminding people that you can always decline to answer a question. That would be better than giving us false data. So they're really on top of it, and it's a joy to work with them. And not only am I developing a relationship with them because we're working together for 2 years, and I also talk to them every 2 weeks, but that's something that's been interesting to manage is they're also developing a relationship with the participants because they're calling them every 2 weeks for 2 years. So I do have the interviewers at the end of each survey mark whether or not they gave the participant information, because we do think ethically, and it's important if someone asks, like, what is PrEP, that we tell them. We tell the participant, we'll tell you at the end of the survey, but the panel effects are something that I think we're paying attention to, and I'll talk about more in the limitations. So our response rate to date has been good. We're back up to about 77%. We have a couple more weeks of data collection than what's on the slide, but this is the response rate to date for each fortnight for the data that I am presenting. So we're happy with this, and this is what I expected based on a weekly phone survey we did in Lesotho. And about 60% of participants have responded to all 13 weeks. So we have a decent response rate and group that is responding. So like I said, we call every 2 weeks. So that is a fortnight, not to be confused with fortnight. Just to make clear what fortnight I'm referring to. So what are we asking them every fortnight? We're asking them, how much money have you been made or given in the past 2 weeks? Where have you been in the last 2 weeks? The last time we spoke, you were in Princeton. Did you spend most of your time there, or did you go somewhere else? We ask them if they're in school, how frequently did they go to school? Then we move on to if they're pregnant or not. We ask, how much do you want to get pregnant? How much do you want to avoid getting pregnant? How likely do you think it is you got pregnant in the last 2 weeks? Then we move on to relationships. We say, the last time we spoke, you had a boyfriend named JB. Do you still have that boyfriend? And this is actually something that interviewers helped me with. They said, but there's actually a lot of people getting in and out of relationships with the same person, and they don't want to do the whole relationship inventory when they get back together with this person. So can we adapt the survey so that if they tell us, like, oh, this is a boyfriend I've had previously, we don't have to ask the 10 to 15 questions about the person? I was like, yes, that is great feedback. So we do quite a bit of relationship inventory. We also ask relationship satisfaction, which, like, anybody, think about 2 years of biweekly data about relationship satisfaction. Fascinating in and of itself, and maybe not something we want to see, but that is a great question that one of my colleagues suggested we ask. We also ask every 2 weeks, have you had sex in the past 2 weeks? If yes, did you have vaginal sex or did you have anal sex? It's a very heteronormative definition of sex. We have one participant who has a female partner, and so we do try to say to her, we're defining it in this way because that is what we're looking at in terms of HIV risk, because we don't want to invalidate her experience, but we want her to be a part of the study. And then finally, anyone who's HIV negative, we ask them, have you tested in the past 2 weeks? If yes, what were your results? Have you taken PrEP? And then what do you think your risk of HIV acquisition was in the past 2 weeks? So for the analyses I'm presenting today, we have 237 women in our study over 13 fortnights. So we excluded anyone living with HIV as they are not at risk of acquiring HIV. We did exclude anyone with less than 50% of survey weeks because we felt like the imputation wouldn't be as valid as we would like. And then we did exclude our one participant with a female partner as we're looking at heterosexual risk of HIV acquisition. So I'm going to talk a little bit about sequence analysis and what exactly it is. So it is a data reduction technique for classifying longitudinal data, experiences from a pattern-based perspective rather than a variable or event-based approach. I was sharing this presentation with a colleague, and his first question was, why didn't you just do a latent class analysis? And I was like, that's a decent question. We love latent class analyses in public health, but that it would be looking at the underlying variables of each participant. And what we want to look at is how her practices are unfolding over time. So we're taking a different angle. And again, it answers the question, how do processes of categorical states develop over time? We create typologies, groups, or clusters, and then we then talk about those clusters. So I think, as you all may know, as this is a more sociology heavy department, like in public health, we haven't used sequence analysis as much. So when I looked in PubMed for examples in public health of sequence analysis, it's growing interest in our field. but it's not something that I was taught in my training. So there's a 3-step process. First, you create sequences, and then you do optimal matching and cluster analysis. So let me tell you about the states that I created. I created 5 states, and I'm going to explain to you how I came up with each of these 5 states. So you can see on the slide the 2 questions that I used to create this first state. If someone told me that they had had sex in the past 2 weeks and they had taken PrEP, I put them in the yes PrEP, yes sex group. Someone did not have sex but took PrEP in the past 2 weeks, I put them in the yes PrEP, no sex group. And then someone who hadn't had sex and hadn't taken PrEP was in the mint green, no PrEP, no sex group. And then we get into a little bit more complicated with condom use. So if someone hadn't taken PrEP, but had had sex and told me that they used a condom each and every time they had sex, we put them in the no PrEP, yes sex, used condom group. And then anyone who said either they didn't use a condom any of the times they had sex, or they only used a condom most or some of the time, were put in the no PrEP, yes sex, no condom group. So what happens in sequence analysis is you assign everybody a state. So I assigned each of my 237 participants a state for all of their 13 fortnights, and then you kind of get sequences as shown on the graph here. This is just a quick sample that I wanted to show. So my step 1.5 was conducting multiple imputations. I had almost 10% of missing data. You can see about half of my gaps were internal gaps in the data set. 16% were initial gaps and 30% terminal gaps. We were able to assume missing completely at random or missing at random. I used the sequence impute package in R. And the way that they impute gaps in sequences is very interesting. They start on the outer edges because they think by filling those first, you'll have better information to fill the inner edges. And then you stack these data sets. I made 5 data sets, so I'll be presenting the imputed data. All right, so we have our sequences. What's next? The next step is to assess to what extent sequences are different from one another. The goal is to quantify how similar or different 2 sequences are by calculating the minimal cost of transforming one sequence into another. So how you transform sequences are up to you. It's up to your research question. So you can add a state, you can remove a state, or replicate a state. And each operation has an associated cost. So if I want my sequence to match someone else's, you decide what you want to emphasize. And I was interested in duration. You can also emphasize ordering or timing, but I was interested in putting people together that spent a similar amount of time in a state. So I wanted to put people who'd spent a lot of time not being sexually active together or using PrEP together. So I decided to emphasize duration. So what happens is a matrix is created of all the scores. So every single sequence in your data set is compared with every other sequence, and you create a matrix that has the cost of each transformation. You then use these matrices of dissimilarity to combine sets of sequences into meaningfully similar groups, because our goal, again, is to identify meaningful clusters of sequences. I used the word method, an agglomerative hierarchical strategy that begins with a set of clusters that each contain one sequence. That's what's on the bottom of the axis here, is a cluster for each person. And then you put similar clusters together. This is my dendrogram. Then you can kind of look across and see like what number of groups might be meaningful. You also use standards of cluster quality. It's not just a dendrogram, but this helps you give an idea of kind of an important cut point. You also should consider the content validity of adding a cluster. So that's just my quick primer on sequence analysis. So we can move on to the results. So what did our analytic sample look like? Our participants were a little bit older than our general cohort. That was the one characteristic that was statistically significantly different from the overall sample. So we're a little bit older, but there's still plenty to talk about among this age group. About half had given birth, half hadn't. 90% were in a relationship, of whom 8% were married. A third are using modern contraception other than condoms. 18% don't know their partner's HIV status, 80% know their partner is negative, and 2% have a partner living with HIV. And then 88% reported that their partner knows their HIV status. 53% have been paid for work in the last 7 days, and 57% are living where they did in 2021. So that shows that some people still haven't really left the home. So when I compare my overall sample, like the 321 women, to the face-to-face sample, I was very happy to see that there were no statistically significant differences, which again is pretty rare in phone surveys in sub-Saharan Africa. I think this has been a great place to have a representative group. So let's start looking at results. Overall, 81% had reported at least one fortnight of sexual activity, but most people are not often reporting sex, but this matches what we know about young people. Sex is not actually that frequent. So you can see that it really tapers off after 3 to 4 fortnights of report. Again, 19% reported 0 fortnights of sexual activity out of the 13. That just gives you an idea of one of the first aspects of our states. Next, I'll tell you a little bit about condom use. So we asked a couple of questions. First, did you use a condom during any of the times you had sex? If they said yes, we then asked, how consistently did you use the condom? And I'm so glad we asked this question because it really impacts our estimate of condom use. So they can respond each time, most of the time, or sometimes. And then finally, we ask, did you use a condom the last time you had sex? So what did we find? Putting the data together from all 13 fortnights, condom use was reported at least once in the past 2 weeks for about 50% of interviews. And then of those who said yes, they had used a condom, 35% used a condom sometimes, 12% most times, and only 52% each time. And then when you compare that to condom use at last sex, you see that condom use at last sex is reported 78% of the time. So you get a very different estimate of condom use. When you put together each time among the 54%, you see that 28% of sexually active participants are using condoms consistently, which is very different than the 78% at last sex. A lot of people just ask last sex. So this is something I'm interested in talking more about, not just from an HIV prevention angle, but also from a contraceptive use angle. Like we still count condoms in the same way that we count an IUD, which is wild because condoms are like a sex-specific act and an IUD often stays for years. So that's just a rant I'll save for a paper, but condom use when we actually start looking across time, which is one of the strengths of this study. So 80% of those who were sexually active reported a condom use at least once. And I did look and see that the percent using a condom did not differ between those who'd ever used PrEP and those who hadn't. But 82% of condom users reported at least one instance of condomless sex, which again, like over almost 8 months, there may be a change in relationship. It might be normal that people stop using condoms. And that's something I want to look at next is the timing. We can look at relationship duration. It was really interesting in baseline data collection. We asked the question, like, when did your relationship begin? And we had a question for people who weren't sure of like, what season was it? Was it spring, winter, summer, fall? We did not use that question once. Like everyone knew the date of their relationship start. So we're going to be able to make a relationship duration variable to see like at what point is condom use stopping. And then 25% of people who had sex with a condom reported sex without a condom. So we're seeing a fair amount of back and forth. Moving on to PrEP. So we ask a very basic question. Have you taken PrEP at all in the past 2 weeks? We don't follow up with an adherence question, like how consistently did you take it? We may add that for year 2, but for now, this is the question we ask. 1 in 5 have ever reported PrEP use. And then out of the 13 fortnights, the mean nights on PrEP was 4. And the median nights was 2. So that shows you that people are really not persisting on PrEP. So let's look at exactly that. The fortnights of PrEP use among ever users. So half of ever PrEP users in our study only stayed on PrEP for 1 or 2 fortnights. The rest are, the other 50% are distributed between the 3 and 13 weeks. But you can see most are really not staying on PrEP for a long time. So this is showing us that PrEP persistence is low. This is good to know because PEPFAR, the President's Emergency Plan for AIDS Relief, the way that they measure PrEP is uptake. And so uptake is probably not a great measure given how much people drop off of PrEP. So let's look a little bit more at PrEP. 98% of participants discontinued within the 13 fortnights. And then 24% of ever PrEP users restarted after discontinuing PrEP use. So that's something that is more novel that we'll be able to describe because we have this longitudinal data. 11% of those who restarted had 1 gap and 13% had 2 gaps. So the question now is like, is this are those gaps lining up with times that they were not sexually active and they're practicing prevention effective adherence, or is it not? And then 25% of ever PrEP users reported condomless sex at least once after using PrEP, which again could be appropriate if your relationship is moving in a certain way. But to go from using PrEP to not using a condom, that's going from like taking a lot of action to not. So I'm curious to learn more. So my first objective was just to describe PrEP and condom use patterns. So I was able to do that. We see inconsistent use of condoms and then high discontinuation of PrEP. So let's take a look at our sequence analysis results. So this is our imputed data. That's why we have 237 times 5 observations. And you can see that young women spend most of their time in the green group, the no PrEP, no sex group. So it's hard to discern a lot from this visualization, but I like to show it this way before I go to the next slide. What we have on the x-axis is each fortnight from 1 to 13. And then each row is a participant. So this is like us zooming in on one participant. You can see a couple nights of no sex, no PrEP, then a couple of other states. So that's just showing you what you're looking at. Now, when we sort the data, you can get a little bit better idea of how people are spending their time. You can see our PrEP users in blue and red are at the bottom. And very few of them are persistent throughout. But let's take a look at proportion on the y-axis and fortnights on the x-axis. So let's start at the top of the graph. And we see that young women are spending 7% of their time using a condom and more than twice the amount of time, 18%, not using a condom. 69% not being sexually active. And then 2% of their time PrEP use aligned with sex. And then 4%, twice as much time on PrEP and not having sex. So let's talk about our states. I was able to describe the states, how many states each person are in. So the 17% that are only in one state, that's everyone who is not sexually active. No one stayed the whole time in a PrEP and sexual activity group. Everyone who was in one state were those who were not sexually active. Participants, of whom 43% were in 2 states, those were people who were switching between not being sexually active and sexually active without PrEP. So that's mostly people who were not using PrEP. When you get to the 3-state participants, almost all of them had time without a condom in a fortnight. And then you've got just 8% of participants who have moved across 4 to 5 states. So you can see that, again, these young women are moving across states at a pretty and having a very varied experience. So finally, let's get to our sequence analysis results. What are the groups that we came up with? Sequence analysis, like latent class analysis, I come up with the group names. So you can see in the top left, we have our group that I say has protection by being less sexually active. So they're spending about 75% of their time not having sex, but all of them have spent time having sex. This is 64% of our population. We've got 13% of our participants in the least time protected group. You can see that orange signifies sex without a condom, and that is about half of the time. We then move to our group that is getting protection from PrEP. They're spending about 50% of their time using PrEP. That's 7% of the sample. And then 60% of our sample we say is the most time protected, who reported no sexual activity in those 13 fortnights. So this is the same data. It's just now shown at the individual level. This was the proportion. Now we have the individual level. And it just shows you again, I think it just helps show the least time protected. You've got that orange for no condom use, and then protection, the blue and the red showing PrEP use. So just again, helps you see how people are moving across time. So my second objective was to identify HIV prevention behavior groups based on sexual activity, condom and PrEP use patterns. And we came up with these 4 groups: most time protected, protection from PrEP, protection from being less sexually active, and then those who had the least time protected because they're spending the most time having sex without a condom. So the next step, the final objective, is to figure out what is associated with being in the groups. And I'm going to share my descriptive results. A lot of people like to do a multinomial regression when they are looking at group membership for sequence analysis. My main goal in my work is to serve the Ministry of Health and they're smart people, but like nobody likes multinomial logistic regressions. They're hard to interpret. And so I do think that the descriptive findings are still meaningful and can always do more multinomial later. But I'm going to share these descriptive findings of who's in each group. So I'm actually going to focus on these last two groups on the slide, those who were in the PrEP use group and those who are not sexually active to date, because they're very different. You can see that almost 50% of those who were not sexually active attend school, where only 11% of those who are using PrEP reported attending school. So a big difference in school attendance. Next, we look at using a modern contraceptive method other than condoms. 2/3 of those in the PrEP protection group are using a modern contraception. And this is like my project for next year, is to look at what's happening first. Is it that people start using modern contraception and then they use PrEP, or vice versa? But you see that those who are not sexually active, fewer of them are using a modern contraceptive method, which makes sense because they are not reporting as much sexual activity, if at all. Next, we look at parity, if they've given birth or not. So 83% of those who were in the PrEP protection group had given birth. That is compared to only 29% of those in the most time protected, or the group that was not sexually active during that time. Finally, we look at the type of relationship that people are in, and we'll continue to compare these bottom two groups. So among those who were in the PrEP protected group, 28% were married. So that's really interesting to me, that those who are married are more likely to use PrEP. I'm not sure how they're conceptualizing risk, but I would like to learn more. We're putting in a grant to do some qualitative research. I think that's important to take a look at. And then no one in the most time protected group was married, and 42% were single, which is a much larger proportion than the other groups. Which also does validate a little bit. It does make sense that like the way that we see those who are in the less sexually active group have some characteristics that make sense in that way, which is a nice way to triangulate. So my third objective was to present the characteristics associated with each HIV prevention behavior group. And we see that those who have the most time protected, oh, this color is very different than what's on my screen. Well, the most time protected group, which is green for me, but blue for you, half are in school, there's low modern contraceptive use, only 1 in 3 have children, none of them are married, and most of them are single. That is in comparison to our PrEP group, which people are mostly not in school, they're using modern contraception. Most of them have had kids, and about a quarter are married. So we also have the description of these other two groups, but I think the contrast here is really interesting. So let's move to a couple slides for discussion before we open up to the group. In summary, I'm able to describe PrEP and condom use patterns in a way that most people aren't, because we are calling so frequently. We see low uptake, low persistence, and our participants spent 6% of their time overall on PrEP, but more time on PrEP and not having sex than having sex. So they're not being as effective as they could be, but also that's life. We then identified these 4 protection groups, and we're able to describe the characteristics associated with each group. So what does this mean for public health? We are providing an example of how these young women are having a hard time aligning their risk with HIV and their protective behaviors. We also see very short duration of PrEP use. I think people kind of knew that people were not persisting on PrEP, but I think this is to a degree that people might be a little bit surprised by. And this also tells us that if we are using PrEP initiation as our main metric, that we are grossly overestimating PrEP use. So there's been about 100,000 PrEP initiations in Eswatini. My Ministry of Health colleagues said that it's actually PrEP is available in all health facilities in Eswatini because all health facilities have ARTs. Because HIV prevalence is so high, it was pretty easy to integrate PrEP into those health facilities. So it's very available, but people for some reason are not persisting. And I asked my interviewers the other day, like, why do you think there's high drop off? And they had 2 reasons. 1, side effects, and 2, they're like, there's a high migration in Eswatini. People go to South Africa to work. And so you see, they said that they thought a lot of people's boyfriends were like in and out of town. So that's just hearsay from my interviewers, but I think there is some literature that validates that as well. So in terms of informing HIV prevention strategies, I'm very interested, as I said, at looking at PrEP and modern contraceptive use. And we do see huge differences by group. So how do we use these differences? How do we use this information that we've created from the sequence analysis? Well, I like to think about our Ministry of Health colleagues and like where they're going to reach adolescent girls and young women and like what should the message be? Because if we're going to schools and we see that, you know, young women in schools are about half of them are not sexually active, or let me put it the other way, those who are in the most time protected group, about half were in school. If we're going to schools and telling people like, you know, immediately get on PrEP. No, we need to like tailor a message and say like, you know, down the road when you need it, this is what you should know about PrEP. So thinking about, you know, how do people move between these 4 states? Is it that people who are in the kind of not sexually active group, are they jumping to this group, to the last sex group, and then moving to PrEP or to least time protected? I'm very curious to see like how within these 4 states do people move across time. So that is something we could do with our 2 years of data, is to like basically do a sequence analysis for each quarter and then see how people are transitioning to groups. But I want to think about where can we reach these people. So those who are in the most time protected group, they can be school-based for some interventions to think about what is their life looking like. It is less sexually active and making that message appropriate. Those who are less sexually active, about 50% had kids, so you could meet them at the antenatal clinic. Finally, those with least time protected, you could meet them at the antenatal clinic and family planning clinic because those were where they were available. And then the PrEP group is already being reached. So I'll pick just 2 limitations to share so we have enough time for questions. I've already kind of talked about panel effects. I want to talk about the PrEP measurement is coarse. So we don't actually know how adherent people are, but given that we see that they're only spending 6% of time on PrEP anyways, we see that it's really the persistence that's the big adherent right now. And then finally, this was a good conversation I had with my interviewers about how to collect the data. So my interviewers were like, Abba, do you know what a situationship is? And I was like, yes, a situationship is where you like have a casual sexual partner because it is convenient. They were very relieved they didn't have to explain it to me. And they said there's a lot, not a lot, but there are situationships or casual sexual partners that our participants don't want to report because they don't know how old the guy that they had sex with is. They don't know how many biological kids he has. They don't know his educational level. So this was a great switch we were able to make in the survey to actually just have them be able to report a casual sexual partner rather than trying to take like a giant inventory to encourage people to report. So I think the other limitation is the generalizability of sequence analysis results. You know, it is the findings are specific to the data set, but I do think that the way that we've seen the women divided can be used in other contexts. Especially, it was interesting that women who use PrEP are different than women who use PrEP consistently. So that was nice to see in my results. So thank you very much for your attention, and I look forward to your questions.